You would think that way people want like
hospitals anymore. It's one hospital with two separate buildings. Like you're not going to.
I'd like to call the January 2026 meeting of the Indiana Emergency Medical Services Commission back order. And then please call for information.
Lee Turpin,
Here.
Sharon Puckett,
Here.
Dr. Lisa Clooney. Here. Dr. Matthew Shady,
Here.
Jerry Harder.
Here.
John Zarman,
Here.
Dr. Sarah Brown. Here. Matthew McCullough,
Here.
Andrew Bowman,
Here.
Mary Ann Dudley,
Here. Here.
and Lori Bailey. Dr. Eric Gabriel.
Here. Everyone, please stand. Please flag.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you and welcome to May with the Indiana Municipal Commission meeting. We'll move forward. Anything else, please? No,
the only announcement I'd have is we did have up there, and I think we have in the chat, if you'd like to continue education credit, we encourage you to use the QR code to sign in. So,
I'll move on with adoption of minutes. Pleasure of the commission.
motion to approve.
Second. Seconded by Commissioner Puckett. Any further discussion or corrections? Hearing none, we follow the roll call.
Yep. Steve Urban,
Aye.
Darren Hoggett,
Aye.
Dr. Clooney. Aye. Patrick Hutchinson,
Aye.
Matthew Shady,
Aye.
Jerry Harder,
Aye.
John Gartman,
Aye.
Dr. Brown,
Aye.
Matthew McCullough,
Aye.
Andrew Bowman.
Aye.
Mary Ann Dudley,
Aye.
he's in an airport, so you may not hear us. Lori Maley
Aye.
and Dr. Gable.
Aye.
Hey, it's Jim Nossett. For some reason, I'm not hearing my name called each time, but I think you are. I am here.
Awesome.
And aye to the adoption of minutes.
Minutes have been adopted?
Yes.
So we move on to honoraries.
First of all, start on a sad note, announcement of a line of duty death that's being treated as such from Wednesday, January 7th. We have the passing of a paramedic from Lutheran EMS, and that was Jake Amos, and it is currently been an EMT since 2007, paramedic since 2010. We have more details on that. That unfortunately was a suicide, which I was unclear. I did not qualify, but it does qualify under the Public Safety Officer Support Act of 2022 if there is a diagnosis related to the work condition. And he had responded on a horrific school bus crash in 2018 that you may recall or Fulton County that had 3 siblings that perished, and the other driver was a drunk driver, but it was kind of a horrific scene, and I believe there is a diagnosis from that incident. So that is being treated as a line of duty death, so we extend our sympathy to everyone that knows Jake and Lutheran EMS and to the survivors. The other honoraries that we have are pretty much standard. I would note, we had one emeritus, Thomas Grumman, and then we also did have State EMS Directors Award at the Crossroads Conference. I recognized Nate Metz for his service both to EMS in general, but also particularly with the EMS Association, the leadership there, the conference and everything that has developed there. And so I wanted to share that along. Those are the highlights from the recognition.
Any questions for Eric McKinney? Hearing none, we'll move on to reports. Indiana Department of Health. Vince, all right.
Didn't see. Not hearing you.
Vince, can you hear us? See my mute.
Some PC speakers.
There we
Can
go.
you folks hear me?
Yes.
Yeah.
Now we can.
Can you hear us?
I can hear you.
All right, we can hear you.
Oh, you can't hear me.
Yes.
Outstanding. Sorry, I didn't think you could hear. All right. So again, I apologize. Hiccup. I'm on site at another location. I wish I could be there with you today. My reception, I think, is not great. If we do get cut off, I don't have a ton to report to the commission today. I do thank you for inviting me. We can go to the next slide. So again, we always like to share our mission and vision with IDOH. And one of the updates I'm going to talk a little bit about was the RHTP program. I think you're going to have some more about that later too. kind of from my perspective, wanted to make sure that everyone was aware we were awarded 207 million for the first year, which is awesome. It's a little more than we initially set out for. I did include some links if you want to see the announcement from Governor Braun and then the broader CMS assessment. There's a link there for it as well. Obviously, other work groups are in their infancy, but they are starting to assemble and engage for those respective works. Go to the next slide, please. So this is just a quick update of what I presented on last time to the commission. So these are the 12 initiatives, and really the two that are more related to the Trauma and Injury Prevention Division are 1 and 4. So again, just wanted to share that the works have started in those work groups, and hopefully as we move forward, I'll have some more information to share with everyone. But they're all just really at this point getting set up, make sure we have the right players at the table to get discussion started. Again, there's the link for the actual grant at the bottom of the page. If anyone hasn't looked at that and you're interested in seeing what we actually submitted for, feel free to go to the FSSA website and check that out. Next slide. So I did want to make folks aware that we do have a request for application open again. So there's a link there at the bottom where you can find, pardon me, some information on that. Really anything related to those key strategy areas, and as far as trauma system development, quality improvement, trauma, non-trauma center engagement, and injury prevention programming. So again, just let you know it has been reopened. We have some funding to be awarded. So please, if you think you have a project or you have some work that is trauma or trauma related and to any one of those kind of areas, we hear about it and support it, support that. So next slide. So we do have an upcoming GC meeting on February 6th. Just wanted to share with the group. And then our subcommittees here are dates. So I have no subcommittee update. They haven't met since I've last reported to this group, with the exception of the registry subcommittee just meeting on January 7th. Really not a ton coming out of that on this meeting, just getting set up for the 2026 year, looking at some objectives to move forward on as far as quality data and getting submissions from hospitals that are not reporting currently. So really nothing new that I haven't reported on in the past. And next slide. Yeah, that's short for me today, but if anyone has any questions, happy to field anything now, and or there's my email, and always happy to reply and help any way I can beyond that. So thank you very much.
Thank you.
Quick, Vince, I know you guys had the informational meeting yesterday statewide about the regional grants. Was that recorded to where we can share that? I've had a few people reach out about that.
You know, that's a great question. I literally found out about that meeting while I was at a different District 2 meeting yesterday. I wasn't even aware of that meeting prior to maybe an hour or two before it went live. I'm going to look into that. One of my employees, one of my staff members went to it. So I just haven't had a chance to debrief. I was on the road all day yesterday and I'm on site today. But that's a great question. I'll look into that and I can share that back with Craig and the team to share with the group.
I think you're good. We got confirmation from elsewhere in the room that it was, so I think we're good. Thank you.
Okay, great. Outstanding. Yeah, I got to look at it myself, so.
Any questions for Department? Okay, hearing none, thank you, Vince. Legislative update, Director Kim.
Most wonderful time of the year. We have started legislative session. So this year is a short session, which means that it's a non-budget year. They will not hear anything that has budgetary consequences. The bills that I have are just a few. The deadlines were the past 2 days, but they also sometimes they go through legislative services before they appear. So we could add to these as it goes along. And this first one is an example from what I emailed out. The fire marshal sent this to me late in the day yesterday, because I normally would not read through housing matters bill and about residential code. But he said EMS might want to track or weigh in. He was pretty certain the fire service would, but allows residential buildings with 5 or 6 floors to have a one single stairway for certain requirements and a passenger elevator that accommodates a wheelchair. And so that means that cots might not fit. So when you're looking at unresponsive patients and stuff, it could be taken from a 5th or 6th floor all the way to the ground. And so that's something that I would encourage people to kind of track that and see if it goes anywhere. It is a rather large residential code bill. But that was the one point that we wanted to flag. 1003 is the follow-up I had indicated on boards and commissions. The first draft, it's such a large bill, it's a little hard to track. I went through it pretty intensively, and I don't believe the EMS commission is listed. But there was serious talk about merging the EMS commission and the Board of Professional Standards for fire. And I have heard there may be consideration of amendments. And so I think I would encourage people to be diligent and track that bill. It may potentially be heard coming even next week. But it's in the government regulatory reform, and that could have a direct impact on an EMS commission as it stands. I would note, I should have started with the legislative year. One of the things that I caution is, remember that the commission are appointees, and I'm a government employee. And so if we speak on legislation, pro or con, then we need to seek permission of the governor's office to do that. And so if you have strong feelings on the bill, just make sure you aren't testifying, things like that, because you would need to seek authorization to do that or risk your appointment. And so I wanted to relay that. House Bill 1060, Emergency Medical Services, is a law that addresses requirements for educational institution degree programs. They have to produce so many graduates during a time period, or they have to get a special waiver. And Representative Garcia had reached out to us. We worked with her on the mental health items, and this was flagged for her from somewhere, and she had authored it. We had spoke with Matt as a representative of Ivy Tech, not sure the direct impact on them, because of them having all the campuses are probably not calculated independently as a whole. They probably meet the minimum. But it is a bill that's out there, and what it basically says is it kind of zips them from being eliminated if the minimums are not met. So it is kind of positive. If it goes through, just questionable whether it needs it or whether it will advance. House Bill 1202, public safety matters, is what we would normally call an IDHS bill. It's our agency bill. It's a public safety bill. It actually includes a couple other of the agencies in the public safety sector or the vertical that's been identified. And the one thing in there directly impacting EMS is legislation that would require EMS personnel to undergo background checks. You may recall we adopted a rule, and we had broad support from the public and the commission to do the rule. We went to enforce the rule, and the state police said, the FBI says we cannot release results to you. The only way they can do it is if it's in statute. And so Justin Goodell, our chief of staff now, our former general counsel, he and I kind of did a special explanation that the commission acts on behalf of legislative initiative. You're appointed by the governor, and the FBI has not accepted that. So we have now gone the route of asking a statute that would cover that. It basically says individuals that are certified have to submit to a national background check, and that the state police department shall release the results to the Commission on Homeland Security. And so that means we would be authorized to have that one. We'd have a physical statutory requirement to do the background check. Secondly, we would have authorization to view those and then be able to vet. So It just kind of corrects the challenge we've had with the FBI. We have not been alone. There is federal legislation that would make it easier for that. But the FBI is very protective of the data they release. And so that's why we ran into that challenge. It did unanimously pass committee yesterday, and it's eligible for a second reading on a floor vote in the House. House Bill 1251, Emergency Ambulance Services, basically as a follow-up from Representative O'Brien, had been working, and it would basically require county commissioners to identify areas that are unserved, and then they would need to provide emergency ambulance services. And they can do that through a variety of ways, either a public service, contract with private or nonprofit. But they would need to make sure that there's coverage for everyone in their county. And this is part of the ongoing effort to more clearly define the essential service aspect of EMS. It did have discussion. Interestingly, the representatives of the commissioners and representatives of counties and cities spoke, and they are supportive of the initiative, but they were saying if it passes, they would like better funding in order to be able to fund it. And it did pass committee unanimously, despite their kind of cautions. So those are the current bills that we have out there right now. I always will update, and I'll email out from time to time the commission. I sent out that first update, or Emily did on our behalf, but we will get those out to you during legislative session. With that, I stand open to any questions.
Hearing none, we will move on to EMS for children. Margot Canal.
Margo could not be here. She is doing an exercise. She sent her regards and indicated her main thing is our big discussion point, just like Department of Health, would be tracking rural health transformation program, RHDP, and the pediatric and OB focuses. And they are a stakeholder with that, along with IDHS, IDOH, and FSSA.
Any Fire Chiefs Association, EMS Division, and Jared Sykes.
Jared texted, he might not be able to join. He said he got called into a meeting. His main thing was just, the placeholder, which I have up there for the Indiana Fire and EMS Leadership Conference. I would note, I think as a sign of a positive gesture, and thank the fire chiefs, they have invited, and the fire marshal attends their board meetings, and they have invited me, and I sit in on their board meetings when I can, to kind of allow for flow of information. So that's been positive from their aspect.
Indiana Emergency Services Association.
Good morning, everyone. Just want to take a brief moment of your time to kind of first off, thank you all for all that attended our conference. We had over 480 participants this year. Again, it was it filled my cup, overflowed my cup at the end of the day. Watching everybody kind of talk about the awesome things that we were doing. I'm encouraged to tell you all that we have majority of our conference board is back. So that progression that we've made over the years, a couple of years is coming right back at it. We started the process already of getting the executive board together to start moving forward. Applications for presentations are open now. So the abstracts are open now. We're going to do it earlier so we can get the announcements out. We'll have it on the website here probably at the end of today or this weekend. But you can always Google search 2026 IAMSA ENA conference, and the abstracts are available. Just a couple other things to keep in mind. And there's also a form going around if you didn't pick one up from Jeremy. We do have a QR code that does link you to the abstracts. So if you're interested in presenting, please do so. Coming down the pipeline quickly here is, first is our Running with Shears. Our Running with Shears is May 16th in the morning in Indianapolis. All of our proceeds goes to the Memorial Fund to try to raise enough funds to put the memorial at State House for EMS deaths. That night is our Golden Sirens Awards dinner. Last year, I think we maxed out the tables, so we're gonna add some extra tables this year for all that was there. We are accepting nominations for Golden Sirens, which is anybody over 25 years in the EMS service that you think should be recognized. We start accepting those. You will see, actually, our website just opened today with the nominations, and you can order your tickets. You'll see an email if you're an IAMSA board or an IAMSA member. You'll see an email from me shortly that has the links, and we'll be pushing out some Facebook marketing campaigns as well. Yes,
Same location as last year.
same location, Primo. Everything's the same on that, May 16th, 5 PM at Primo in Indianapolis. I'm going to be working on getting hotel rooms blocked here shortly for that time frame as well. And then towards the end of the summer, we will also be doing our second annual EMS Memorial Poker Run. That'll be done in Vincennes, and that's on September 12th. So, a lot of things happening. Please reach out if you guys have any questions. I'm more than happy to answer them. If you do not have my information or contact, please let me know. I'm more than happy to give it to you. Thank you for your time, everyone.
Interject something. Follow up to my our legislative director staff email, and a couple of bills, 1003, the one that is boards and commissions, and if there was an amendment, it would be heard then, is scheduled for Monday morning, January 12th at 10:30. And then the 1001, the bill on housing with the lack of elevators or minimal elevators, is scheduled for Tuesday, the 13th at 8:30 AM. So just a couple of scheduled things.
Let's see, Education Oversight Committee, Commissioner Zucker.
Good morning, everybody. All right, let's clear off your desk, take out a pen and paper, we'll get this exam started. Some exciting times that have happened this last Monday at the Oversight Committee. We had the opportunity to look at three, Craig, am I hitting the wrong button here? There we go. We had the opportunity to look at all three key elements that the commission asked us to take a look at. It was a very strong meeting. We had a lot of good opinions on all three topics. So I'm going to take a little time today and go over those with you. So the first topic we had was the EMT competency. If you remember, the SIMSCO sent out a document. I think you received that at the last commission meeting, and you may have gotten it here recently also. Identifying that we needed to look at key competencies for the EMT level. This has been done at the paramedic level for quite some time, and we have been meeting the majority of that, except for identifying key numbers and so forth. So with that, what that document does, I did not have an opportunity to read it. It brings in the National Education Standards Guidelines. It also follows the SIMSCO's recommendations, with the exception of one, which I'll identify shortly. And it brings in consistency within the EMT examination and also into the core competency, so forth. So the biggest thing is we really need to tighten up on the EMT portfolio. We have identified throughout the state, a lot of people are doing things differently in that portfolio. So we kind of want to bring that in a little bit tighter. We want to make sure that that is done internally for that internal competency. We also then want to make that portfolio mandated so that we can make sure that students are getting what they need before they come to that testing. We did identify that there were some training institutions that probably were not doing the portfolio, and we need to tighten that up a little bit. The other, let me back up. One of the things with that also, this is not, one of the things we wanted to do with that is to identify the age groups, because that was recommended by the SIMSCO. We weren't doing that in that portfolio aspect of it. So in doing that, what we would be doing here is the SIMSCO's document is still in a draft form, but it's very extensive. It's very good. The aspect of that is they are recommending we have 30 contacts at the basic level. And we discussed that extensively and felt that trying with the numbers of students and so forth, trying to get those clinicals in and making them, solid clinicals, it was a little tough. So we're going to recommend a little bit less, which is 20. And in that, we will be breaking it down into categories to where we'll have 8 adult pediatric patient contacts and 6 geriatric, 6 pediatric, okay, to meet our 20 that we're recommending. And this is a working document. We can always change it later as we go on if we find that it's necessary to do so. We're hoping that if you elect to pass this and adopt this, that we can make this become effective as July 1st. We believe that's enough time to get that out there, that information to those EMS providers. So with that, the recommendation is to adopt the SIMSCO's recommendation with the modification, and I think I passed up that slide. Let me back up here. I am there. There's the recommendation. My apologies. I'm going forward. All right.
Little button goes back.
The other button goes back. Look at this. We're going through this quick. I just failed the exam today. Okay, so here's the slide I want you to identify. Currently, Indiana, we require 10 patient contacts, and those are just mainly, I've observed this, we don't really have a hands-on, in which this other we would. And we would recommend the 20 and then the breakdown of 8, 6, and 6. So with that, let me get to the proper slide here. Man, I'll tell you what.
That's it,
I did.
right there.
All right, so I failed Education 101. One more? No.
The one right there is your motion.
Yep. There it is. Ta-da.
I have to see her here.
You know what?
It's looking back and forth, I have to see her.
Are you're sitting right next to a paramedic, you can take care. So the motion is that we adopt this with the current recommendation of 20 patient contacts, 8, 6, and 6. The other thing I want to point out is these contacts, we really would like to have at least 50% of those to be live patient contacts. And then we can use either simulation or bring somebody in, like if you had your niece, nephew, whatever, and they're in that certain age group of pediatric, you could bring them in and you could do assessments on them and so forth, as long as you document that as an educational component. So there's all kinds of diverse ways of being able to get these contacts versus just having to get them through like an ED. Because originally what we had was those 10 contacts was either done in the emergency room or on an ambulance. Okay, so this is a recommendation, and then we would want that to become effective July 1st.
Emily, do you need that read in the record of the slides commission?
It's legislative.
Budget commission.
Move to adopt.
To adopt by Commissioner Bowman.
Second.
Second. Any further discussion?
So Commissioner Sartman, you're limiting this to absolutely 50% is the max for scenario-based or lab-based?
That is the recommendation. They can exceed that, but at least 50 is the recommendation that they have. And then they can use the other alternative method of validation.
I will say that your numbers seem extreme based on the accreditation requirements at the paramedic level. These seem very high at the EMT level.
So, and we are actually 10 patients less than what NASIMSCO's recommendation is. They are recommending 30 with a breakdown. So yes, with that was a discussion, very extensive. Everybody felt that 20 was an adequate number.
I do respect that. I also am very cautious to approve something that NASIMSO still has in the draft form.
If I can, I think, NASIMSO, it's in draft form because the staff hasn't finalized the editorial stuff. So the board has approved it. We approved it back in December. And that's why it says draft. This needs cleaned up, but that was the document that was approved. My only other comment would be, and I don't know, part of me wants to move it along and give notice, but part of me says sometimes we have these and sometimes we get feedback. And I wonder if we would want to table it for till the next commission meeting to allow comments, because I know we do that sometimes at the registry now, so we don't jump the gun and we allow people to at least make comments before we decide.
I think that makes sense, and I'd be interested in any comments from the audience as well.
Have we, like with Carrie's PI updates, has this been shared with like the PI community? I just was in a training institution that some of those would be hard to get in the EMT course.
I did touch upon that because I also had brought up the advanced EMT. The commission had agreed upon a year and a half, 2 years ago, maybe now, when we were discussing the practical, that that would be adopted, that the advanced EMT courses should be following that. And then I did point out that this was on the horizon, that it was something that we were going to be looking at. So yes, I did address it.
Yeah.
Yeah.
I need to clarify. I thought I understood Mr. Shady's question as he was asking you if simulation could be more than 50%, and you said yes. I thought it was the opposite, that live patients going to be at least 50% or more.
Correct. The recommendation is that at least, so for example, the 8 patient adult contacts, 4 of those should be live.
I think Mr. Shady asked the opposite, if the simulation can be more than 50%. So at least 50%
should be live.
Patient contacts across all 3 age distributions have to be live.
Right.
People,
Right.
not necessarily patients.
So especially, even accreditation has identified that sometimes it's tough to get some of those numbers, especially with pediatrics. So they have opened it up, or it has been open. We agree that you could use an alternative. So for like on the geriatric section, you could get those patients in one day if you can make an agreement with a healthcare facility, an extended facility, just to go in and talk with patients, go through them. And so as long as it's been documented as a true educational component, and you have record of that, and you can show those assessments and so forth, you could utilize those. Those would be live patients, so you could probably whip out all 6. Same way with pediatric, you could use doctor's offices, you could use a daycare, you could bring, a family member in, as long as, so there's alternative methods that you could use. There's some legalities probably to that, especially like going into a daycare. You want to make sure that if you're assessing these patients, that you've got patient parental approval prior to doing that. But I mean, there's some open ability to be able to go to alternative sites.
But again, just clarifying, 50% or more
Should be
have to
live,
be a live patient.
should be live.
The remaining can be a simulation managed.
Can be simulation or other contact.
And one thing I like to point out too is, as we discussed in the committee meeting, is that, remember that I think now we're 4th, we were 3rd, but we're 4th from the bottom nationwide and passed in the national registry at the EMT level. So this is one way we felt that, we could maybe tighten that up a little bit, because students that have more patient contacts and students that have gone through more scenarios tend to do a little bit better on the NREMT exam. So we thought this would be, one way that we might be able to help increase that pass rate. Just throwing that out there.
Then Darren.
Sorry, one of the things that I thought was, interesting, to talk about is, while I do agree with Commissioner Zartman's thoughts of 20 patients and to Carrie's point of more patients are probably better than not, I do want to encourage that we do have high fidelity mannequins. So leaving the real life off and maybe doing high fidelity may be a way to do that, because while you may not be able to get to a daycare, you do have Mega Kids and Mega Go Kellys that you can create to cause high fidelity simulation. While it will take more for the instructors to do so, I do believe that might be a better solution than trying to meet the 6 pediatrics and 6 geriatrics. However, I do also agree that we do need to see more hands-on, not just book knowledge. I think some of our failure rates is because these students are going through class and they're just doing the minimum 10 patients. And if you've been in an ER with EMT students, they just stand back in the corner and not touch anything. So they're not getting that cognitive domain as well. So to me, I like this idea. I'm just speaking in my opinion as a training institution with several EMT courses, both in the high school and then up into hybrid fire EMS volunteer fire classes, that I think the 20 is okay, but I would suggest, or I would encourage a high fidelity, not a real life patient.
And again, remember, this is a recommendation at 50% is the way they have that listed. So.
Darren wants to
Can I
comment.
ask a clarification? Because I think we have some confusion. The numbers for patient contacts and then the individual ages, those are concrete that we would enforce. The rest of the document are the recommendations, so the training institution could determine to use high fidelity or otherwise, correct?
Correct.
Oh,
So the document itself says recommended exposures during the clinical phase, minimum 30 exposures. Since it is a recommendation, why don't we stick with the document's recommendation? And if it's 20, it's 20. We didn't meet the recommendation of the document, but we're not setting ourselves up for failure as a state, not even meeting the minimum of the minimum recommendation.
We discussed that, and then getting back to, Matt's question. A lot of people felt 30 was way too much. They felt that maybe that
It's only a recommendation.
change. Yeah, I know.
It's not required.
I understand. And, we were gonna go that way, and then the group decided that we would go in between. Right now, we require 10. Let's go halfway. Again, it's a working document. We can always make that change later.
You just said required.
So recommended, we can make those adjustments as needed, as we go on with the educational standards. The educational standards are being reviewed currently, so who knows where that's gonna go. So we'll probably be bringing it back again at some point in time. But right now, we've identified that we're not getting even 10 contacts, the way we should.
That's
So,
required.
yeah, do I?
Yes.
I moved it. That's what I would post it out here too. There's two things, and I get it, that there are scheduling issues, there's difficulties in clinicals and everything else. And I sit for a different aspect of, I'm the additional receiver of every product. Okay? And in the last 5 years, the quality of the EMT candidates that we're seeing from almost all training institutions has decreased exponentially. And I don't mean a little bit, a lot, where we're having double orientation times, each basic skills like traction splitting, things that, and blood pressure are one of the largest areas that we're having issues with. I just also sat in a paramedic training institution advisory board meeting where they wanted to cut the internship in half, which I'm just going to state this, I think this is diabolical. I think these numbers need to come up, not come down. I get it, it lengthens programs. I am somewhat tired of hearing that we have to fit the curricula to the schedule. No, we have to fit the schedule to the curriculum. That's what we have to do. If that creates a hardship, that's just going to have to be fine, because we have to assure
a minimum competency when they come out. These are patients' lives that are being dealt with. We need to beef these programs up at speed by time. So with that statement on,
I would move to table.
motion to table,
Second.
second, okay. All in favor of tabling, would you like to call
So with the direction from you, you want this to go back to committee to work on numbers?
it? Just take a vote.
Oh, sorry.
Lee Turbin,
Aye.
Darren Hoggett,
Aye.
Dr. Clooney. Aye.
Aye.
Matt Shady.
Aye.
Terry Carter.
Aye.
John Zarman.
Aye.
Dr. Brown.
Aye.
Matthew McCullough.
Aye.
Andrew Bowman.
Aye.
Mary Ann Dudley.
Aye.
Dr. Knockett.
Aye.
Lori Maley.
Aye.
And Dr. Gates.
Aye. Motion to table, we will address next meeting. Next week.
All right. Our next topic that we wanted to talk about is the psychomotor exam at the basic life support level. As you know, the National Registry has converted the exam at the advanced EMT level and the paramedic level. They incorporated the psychomotor aspect of that exam into their normal exam. However, at the basic life support level, that has not been done. And at that level, we use the registry for the certification level. It is up to the state as to what you're going to do for that psychomotor exam for the final terminacy. What we need to do here is kind of look at the current exam that we have, because they have taken away from those models of utilizing the skills. That's something that is done in the training institution, supposedly before they graduate. They have validated through their portfolio that all those skills have been identified, checked off, valid, and good to go, right? So what we still need to do because of statute is we need to form some kind of an exam. And that identified to us that our current exam is really outdated. So the discussion was, what do we do to make it more realistic? And it came back to the fact that we need to make it more of a mega code style examination. And in doing that, we need to identify both trauma and medical. So what we are looking at doing is probably converting that exam over to a two-station exam, mega code style, which would incorporate all of those skills, plus critical thinking and so forth through that. So our recommendation would be, and there's a typo in this here, is convert to a 3 to 4 station, because we originally had talked about oral exams also, but that should have been done also within the England felt that it wasn't necessary for us to do that. So our recommendation is to convert the exam over to a mega code station, utilizing one scenario as medical and one scenario as trauma. So with that, what we would look at here is this would also standardize the measures and our evaluation tools. We would have to bring this back and develop those through the committee. We feel that that can probably be done within the next 6 months, and that we could get that back to the commission as to what that exam would look like. But right now, we're looking for support in trying to move that exam to converting it from the current psychomotor skills, which 7 stations, you know, your trauma, medical, cardiac, and everything else, over into an actual mega code style exam. So this would be our motion, or if someone would like to, or this would be our recommendation for a motion, if someone would like to take that and allow the committee then to start working on converting that exam and taking it over into a 2-phase exam or 2-station exam, identifying competencies with all of the proper skill checks off and so forth, and develop that, bring it back to you for saying that this is the new exam.
how is the prep integrated into the class itself for the scenarios? How is that?
Sorry, Darren, say it again.
So how's the preparation for the mega codes integrated into the class itself, since there are, there are certain modules and they build upon each other and there are certain skill sets? How is that all integrated for prepping for this type of exam within the class curriculum?
It would be up to each training institution to, develop that. We would not, from the committee side, we would just form that exam composed like what they did as the out of hospital scenario through the National Registry. We would use that model for that exam. So each training institution would have to do the same thing to prepare them for this type of exam.
Follow-up, I think it would move away, the positive is, because I think we presented with the commission even like 5 years ago. And just there wasn't any follow-up, and we were looking at 3 stations, trauma, medical, and cardiac arrest. And now the current model is this medical and trauma, and you have to meet a minimum in each. So that way we don't run into you pass one, fail the other. You have to show competency in both, which matches that competency paradigm. But I think the training institutions have the student minimum competencies, and part of having those, they go over the skills and they are supposed to do the mega code. So I think it would reduce the concern with the traditional way that we still do it is we teach to the sheets. They don't really learn the skills. They know the sheets and what they need to pass. And it would reduce reliance upon that. But yeah, the training institutions would have to.
And they have the portfolios they need to.
Yeah. One of the things I think is real important, both with this and what we talked about before, is that portfolio. And that's something that I think we need to, and the state needs to look at when we have a high failure rate. When they go out and evaluate that course and so forth, is to show me that person's your portfolio. And that would help us identify then, were you really taught and checked off on those skills? Because I think you'll find that those that are failing the exam are identifying they probably didn't get a solid education. Just food for thought. We don't have any proof, but we believe that's where it's at, just from discussion.
So my question is twofold. Obviously, registry has gotten away from skill testing at the paramedic level. Has there been talk of them getting away from it at the EMT level? And so where are we on
I'm
that?
going to refer to Craig since he's on that board.
Was cautious to speak out for the registry because but based on my participation in the meetings, they no longer, they leave that, they defer it to the states. And that's why those skill sheets are not being updated and such as they released the final version years ago and they're like, we're out of that business. But it puts states in a little bit of a quandary because on the paramedic level, they have added questions which goes in the psychomotor domain and they could look at those practice. Currently, they are not doing that, and I don't believe there's immediate plans to add that to the EMT.
Illinois, I believe they do it, they do scenarios, but it's done within the course itself. It's not done separate after the EMT course. I believe it's how they're doing it.
And I think that kind of adding on to that, I think ours is statute regulated. At this point in time, we still need to do that internally. And it makes me a little apprehensive to think about that for the training institutions when we know maybe portfolios aren't being done, but this be done.
And that may be a question is, do we, and I brought it up when I was advising the committee, do we eventually want to drop the practical requirement? Because they're asking us to evaluate statutes and remove parts you don't need. And that would be the simplest, but without a verification, you would totally be relying upon the training institutions that the people are competent.
I think that would be a perfect world, is if we can get into a place where we can verify the competency that everything is being trained correctly and the portfolios are right. I would absolutely support elimination of the practical, that it does have a statutory change, obviously. But I think we have to get that quality question figured out first.
The other part of my question, and I realize this is in the infancy, based on the mega codes, what is the concept? Is this gonna be like the 20-minute paramedic mega code? Mandatory to sit there for 20 minutes staring at each other regardless of what's going on? I always had a problem with the time.
So my answer to you, just from an educator, is yes, no. I think the 20-minute is ridiculous. And I think when we develop this, and again, this has not been developed, we have to go back and there's a lot of work for us to do to put this exam together. I think that those are things that have to be brought in. I think we would use the concept of, remember the skill sheet for that station. I believe that would be in line. And I think it would be a good tool to kind of model from, but I think it needs to be a little bit more realistic. As long as we're looking at critical thinking skills and we can validate that they are assessing a patient and they're properly transporting the patient and the proper interventions, I think would be the key elements. I'm not so sure about time. Just opinion, that's not from the committee. So this will be our recommendation that we would move forward to converting that over to a 2-station exam. And make a code style exam. And then we would allow the committee to move forward in putting that exam together, bring back for final approval to the commission on the exam, what it is.
I'll make the motion for the commission to continue to support the oversight committee on their continued work on psychomotor exam to bring back more information.
Motion by Commissioner Dolan,
Second.
second by Commissioner Bowe. Any further discussion? Emily, if you please call for the team.
Okay. Lee Urban,
Aye.
Darren Hoggett,
Aye.
Dr. Clooney. Aye. Patrick Hutchison,
Aye.
Matt Shady,
Aye.
Jerry Harder.
Aye.
John Zartman,
Aye.
Dr. Brown,
Aye.
Matt McCullough,
Aye.
Andrew Bowman,
Aye.
Mary Ann Dudley,
Aye.
Dr. Noffitt,
Aye.
Lori Bailey,
Aye.
and Dr. Gates.
Aye.
Motion passes.
Thank you. Okay, now we'll have some discussion. Advanced EMT. Wow, this took up the majority of the committee's time, really good conversations. It kind of went this way, in a why. We were originally asked to identify and look at the issue of services being called to hospitals to transport a patient on a monitor to an alternative care facility. And some of the issues there was they would get that patient to that facility and that facility may reject the patient because they don't use cardiac monitors at that location. So it put the EMS crew into a bad position because now what do you do with the patient? Because you take the patient back to where they come from, they're going to say, no, we dismissed that patient. The other part of that was the persons weren't trained to utilize that monitor. And that was the request for us to do, is to look at what can we do to allow the advanced EMT to use a cardiac monitor to transport that patient. And one of the things that they had asked for was, could they have the old ruling that we had many years ago, to where the advanced EMT was able to use the 5 rhythms. And the 5 rhythms was VFib, VTAC, asystole, normal sinus rhythm, and PEA. Okay. Well, the question is, one of the questions that came up was, why are we transporting somebody on a cardiac monitor to a facility that's not going to monitor them? And that's kind of putting that crew into a bad position. Okay. So we identified this way before, and we asked that the physicians go back to the physicians to get the information out to the physicians, not to do that. Okay. But sometimes they sign that medical necessity form and they call for the crew to go ahead and transport that. So the committee decided that, like I said, it went to a why. And there were a few people in there that talked about, well, you know, if we do this, then we need to make sure that they're competent in reading a monitor. and 12 leads and so forth. And currently our rule states that they can transport or they can perform a 12 lead and they can transmit that to the hospital so that we can have earlier intervention. And we found that also in that discussion that a lot of people never do the telemetry aspect of it. They just hand it off to another physician or the ER nurse or even to a paramedic at the scene, which does help because that EKG was done quicker, but again, it doesn't follow what our current statute is. So one of the things that we discussed was how do we get this information back out? How do we make sure that everybody's doing the right thing? And everybody came back and said it's not going to happen. Well, then it went to the why. As to if we're going to have the advanced EMTs doing a cardiac monitor, we got to make sure they're properly trained. They know how to treat that in case there's some kind of intervention done, and they'll have to treat that with pharmacology. So the recommendation came back in short that if we look at this or we do this, we need to make sure that the advanced EMT has been trained at probably the paramedic module level of cardiology and pharmacology, including ACLS, PALS, and so forth, which is time intensive. And realistically, if you're going to put somebody through that, you might as well just go ahead and add a couple more months and they become a paramedic. Okay, so that's kind of where it went. Our recommendation at this point in time is we're not 100% sure that we should just do a monitor course of the 5 rhythms and allow people to do these transfers. We think that it's a much bigger picture. If we need to look at this advanced EMT aspect and we're going to change it, then we need to change it as a whole. And in doing that, we need to include those different modules and so forth. So one of the things that we'd like to do, if the commission wishes for us to move forward in that type of recommendation, is that we want to do surveys for both the providers and also for the individuals. First off, with the individuals, will they want to do this because of the time commitment? The other aspect of it is with the providers, are you prepared for the cost change? So we're going to have to look at not only the 2 surveys to see, is this something that we really want to do? Is this something that people would do? And the reason we would look at it in an individual component is time, but not only that, there's a cost factor to them, okay? And also then to the provider. With equipment, training, quality assurance, all those different things we need to look at to make sure that we're making a good, sound decision. Do we want to move in this direction or not? I think one of the biggest things is that fiscal impact that we're going to have to do because there is going to be a cost factor from both sides. And I think that's key to this as to what that cost is going to be both for the individual and the provider. So if we do this, we need to develop a pathway for this. We'll have to develop the course. We'll have to, and probably the easiest way to do that is to just we would borrow the modules from the paramedic curriculum, both pharmacology and cardiology, and then we would look at what it would take for clinicals to check them off also. I'm sure there's unforeseen issues that we haven't even identified yet. So those would be brought into the place also. One of the other key factors is we need to talk with training institutions because training institutions, are they willing to put this course on? Okay. One of the key things that bothers me with this is I don't want to see us in Indiana, and the committee agreed, just getting back to where we're fragmented at that level. So we don't want module levels as to where we are with the advanced EMT. Our recommendation is either nothing or that we put the full advanced EMT course together. So that's kind of where we are. We're at the why. We don't know if we want to go this way or that way. And it's up to you to tell us, do you want us to move forward with this and work on developing a modified advanced EMT program versus what Indiana has now? But our recommendation or our guidance is that we did not feel that just giving some kind of a monitor course to somebody to transport and not be able to do anything was not the proper way to go.
Commissioners are
Yes.
a few points to ponder. I've gone back and forth on this topic over the years. As an advanced practice provider in the emergency department, I often make the decision, if I'm transporting a patient, monitor burning. And I've become more cognizant of probably don't need a monitor a lot of the times. And so I check BLS. Secondly, I have never had a situation where I'm sending a patient to a facility that doesn't have the capability for monitoring where I've requested a monitor. If I'm sending them to another hospital, they have a monitor. Not gonna be an issue. If I'm sending back to a nursing home or assisted living, they don't need a monitor from my side, so it's BLS. And thirdly, if for whatever reason, the receiving hospital decides, no, this patient doesn't need a monitor, I don't think that puts the advanced EMT crew in danger. They have to deliver the patient on a monitor as requested by the transferring provider. What the receiving hospital decides to do is on them and not on the EMT. So I think that argument kind of is not as strong.
So kind of backing up on that, of the two incidences that was addressed was one, they arrived on a monitor to that healthcare facility that did not utilize monitor, and they refused the patient because of that. So put the crew back into a situation, we can look at Intella and everything else, but these are the stories that we have heard that has happened, and there is some bizarre stuff that they've
They
been
do
doing.
a stand on what facility.
Do what?
I can do to like that. Transfers that were thought to be to freestanding hospitals that ended up being these, pretty high functioning SNFs. Or monitors were ordered, ambulance arrives on scene, sometimes 2 to 3 hours from their home base with the patient, except because they don't take monitors. And then there's nowhere to take the patient back, and the city facility doesn't go take them back because they've been discharged. It ends up in a 5 to 6 hour standoff with a patient by trying to figure out where they go. And it does have.
Emergency
It does have
department answer for that. Unfortunately.
I think one of the biggest misconceptions is the average emergency room provider understands the implications of what they do when they check ALS and that they need a monitor. A lot of our rank and file providers don't understand what that means and what they've done when they do that. They see a path of least resistance to move their patient to a different facility, and we've tried to fill that gap with education and things like that. And honestly, we just don't see a lot of movement because some of the ones who tend to do that education are already the ones who aren't the problem, so it's been a hard outreach to see any movement from that side of things, because I fully acknowledge we send way too many patients out of the ER on monitors that are probably immaterial and unnecessary. I do think this is an area that's really ripe for study. They did it in the hospital setting. They started to realize, like for just run-of-the-mill chest pain, for a while they would go to upper levels of care, and then they go to telemetry, and then they'd study it and say, hey, once somebody's been monitored in an emergency department for a couple hours and hasn't had an arrhythmia, their chances of having one in the next 24 hours plummets. And I think that is an opportunity for us, because for some parts of the state, it's a non-issue, but for some others, to be able to do IFTs on telemetry, it's a game changer for their practices. And so if a short ER monitoring period can say, okay, now your chances of having an arrhythmia have gone from 20% to 2%, that's something we should look at, but I don't think that data lives in. So I do think that's an area that I think honestly would be right for a pilot program or something like that, given the proper parameters. Maybe I'm wrong, maybe they do that, they have some arrhythmias and we're like, this needs to, it proves our point, but from that standpoint, I do have some concerns in the first response side of things, again, differentiated patient. That's worrisome to me, because we've all seen people that look just fine, then all of a sudden, you're looking at BFib, and I think that's a challenging one to put someone in where, like you mentioned, have limited interventional.
I can remember back whenever we did the whole interpretation and that whole battle. Is this more of a, not to be selfish, but is this more of a hospital or certain area issue as opposed to broad brushing the whole state with an issue? It seems like
I think it happens at all hospitals to some extent. I don't know if there's any certain area that it's high acuity, but it does happen. I
But
think
is
you're
it
right.
more of an issue on I mean, the issue is the hospitals are sending these patients
I
out,
think it's the,
not relaying to the other facility what's coming.
yeah, I think that's probably one of the key factors, but also I think it's just that, and I don't know that process, I'm gonna look at the ER docs, but essentially the ER doc signs that, yeah, they either go ALS or not by the medical necessity form, correct?
I think there's a lot of variability in that. So I mean, just from personal experience over the last 5 years, we've changed that so that the sending provider does have to enter an order into the computer saying how they want it to go. I think prior to that, everybody got put on a monitor in the ED because they were easy and it was in the room, and it makes it easier for the nurses when the patient is on a monitor. So like the entire ED, everybody gets put on a monitor. And the nurses don't have, in general, the ability to make a decision to take it back off. So we were just randomly, you know, everybody was already on a monitor, so everybody gets transferred on a monitor. And I think it helped us to require that the provider be involved and order exactly how they're going.
Go ahead.
My apologies.
Come on, Tom.
So I oversee North EMS direction at Methodist Hospitals in Gary and Maryville. We do a lot of transfers. One of the biggest concerns that we have there is that intermediate tele bed going from North Lakes ER to South Lake Tele. We can't find enough paramedics to do those transfers. I've been on the phone outside right now because we're on bypass for CT scanners. Both our CT scanners are down. We're taking everybody down to South Lake. It's a 20-minute transfer for them. We don't have enough paramedics in Northwest Indiana for those calls. So something like this, these advanced EMTs that could put them on a monitor and transfer them is pretty critical for us. The other side of that, the rural EMS side of things for 911, there have been more and more calls in the rural settings in EMTs that are trying to chase a paramedic or paramedic trying to chase them to get from where I'm at, like in Demont, it's 20 to 30 minutes for a hospital if you're not going to St. Anthony's or Franciscan Crown Point. But even at that, midnight, 1 a.m., 2 a.m., Wheatfield's calling for the paramedic that's sitting at Crown Point that just dropped the patient off. And because they have an advanced EMT, or maybe they don't have an advanced EMT, and they can't function with a cardiac monitor, the patient needs a monitor. We've seen it in Keener. We have our own advanced EMT who cannot put them on a monitor. So she's called me as a paramedic, fire chief in Demont, to get up out of bed, to come to the call, to run it as a cardiac monitor. I do see the advance and the advantage to having an advanced EMT. I also am concerned with how far you go, but I think if you have the resource of a paramedic nearby and they do go into VTAC or they're running VTAC and then all of a sudden, oh, it's on the monitor, they have that right to call for that additional resource. Just my 2 cents. I just wanted to kind of talk about the interfacility more than anything, because we definitely could use it, especially in our area. If I could teach more advanced EMTs, I don't teach advanced EMTs because there's no need to teach. I'd rather convince the EMTs to go to paramedic school at that point. So thank you for your time.
Yeah, thank you.
Sorry, real quick. Charlie Coffell, Vice President of SEALS Ambulance, and not to disagree with what Lee's saying, but from my experience, we've never had a monitored patient that wasn't received at an accepting facility. So I, at least in central Indiana where we practice predominantly, that has never happened. We have no documented cases of that. The other concern that I have is I see more providers, downgrading ALS runs where they do want the patient on a monitor. So you're being monitored at the ER. They desire you to be monitored at the receiving the destination. But when the provider calls, and it's typically not the provider, it's typically the secretary or somebody else, we'll often get asked, how close is a BLS truck? We'll say hour. How close is an ALS truck? 3 hours. Okay, well, the patient's not going to be on a monitor, and go ahead and send the BLS truck. So then we send the BLS truck. They're not on a monitor during that transport, but they're put back on a monitor once they get to the receiving facility. As a representative of the industry, I consider that a failure of everybody in this room. I think we need to focus more on, creating more paramedics. Logistically, I'll take my paramedic hat off and put my vice president hat on. And if we did this, I'm not going to lie, we probably would hire advanced. We'd put them through the training. We may post it at our facility and hire trainers, and we do it. The only other thing my concern is, and this would be, I'll give the example, we do a lot of transports, Fort Wayne coming back here to Indy. If that advanced provider with limited training and education, maybe protocols to treat, maybe not, sees an FLV, a funny little V, they're going to dive into Marion, they're going to dive into Marion East, they're going to dive into maybe IU Ball or Anderson, because I just don't think they'll have the education, the pathophys, the experience, the know-how. They'll just get scared, and there'll be a lot of diversions that are unnecessary. Could be, I don't know, it's my hypothesis, but so keep that in mind as well. Those were kind of the three things with this idea. It definitely has merit. I agree. Dr. Hazel needs to be looked at and continue to be debated, but I do think it has some pitfalls as well. So thanks.
Yeah, thanks. So as you can see, we kind of went to the why. And we just need the direction of the commission as to what you would like, how you would like us to move forward, if you want it to move forward.
The one thing I want to add from staff perspective and also the committee, the reason they came back rather than research itself is once they decided the pathway they were going to recommend, which is the paramedic modules, we know that it is going to be burdensome in terms of the time and effort to do that, the education, requiring advanced EMT providers most likely would all need to make sure they have monitors, and that's a cost. So we would have to change the rules. That's why we're saying, so it's easy to say, yeah, go ahead and investigate, bring all that back. But if we aren't seriously looking at it, it's going to be a huge misuse of resources. Is the reason why we wanted to come today was to, before we proceeded, and I would say, I don't think it's something that can be gathered before the next meeting, because I think it'd take a while to do surveys and all that.
Director Kenny,
Yes.
how does this play into Indiana's role as a member of the compact?
When I had that question, I was minding my own business because I tried to stay out of the advanced UP discussion, but I was asked that. So the way the compact works is we would accept advanced EMTs from other states. They sign on with a Indiana affiliation, and it would have to be at the advanced EMT level or above. So that way they could have that person function. And I believe that the correct way, if they were going to function under that organization's protocols, is yes, they would be that background and function as an advanced EMT. And I don't think you can carve out and just say, well, you can do everything but the monitoring. So I think they would have to come to Indiana as an EMT is what would happen. And because most likely, like right now, we have the Indiana specific modules and they can do it online within a day or two. But this is not something you can do real quick.
I guess I'm asking, is that there's an advanced EMT from another state that can do monitoring, and they come to Indiana, they would be prohibited from doing stuff.
Right. Under they cannot exceed the state's scope of practice.
Thank you.
And I will say out of fairness, I think someone asked me, I don't have numbers, but there are other states that allow advanced EMTs to do a bunch of stuff. Ohio, as we heard, allows them to kind of do almost everything a medic can. But I would say the majority of states, or maybe even 2/3, stick with this is the scope, we're going to stay with it. And that's what I'm trying to encourage us to do as much as possible, because it's easy to help us.
I think nationally, in the near future, that'll probably be relooked at again, so that maybe it's not fragmented so bad as it has. And we know the nightmares that took place when we had the basic advanced EMT, all the other thing. And actually, there was a couple of states that had more levels than that. So, that's one of the things we did not want to get back into. Or we felt we shouldn't.
And just to refresh institution memory, part of the problems having was Joe would work today at ambulance service day, be able to do X number of things and go to the same provider level. Next day, to work part-time, have an entirely different set of scope of practice, do what he did at ambulance service A, and suddenly be in trouble for violating scope of practice. It creates a dichotomy that's very hard for the individual given the situation to not do it.
We actually sanctioned an organization, I won't say because they have complied and they've remediated everything. But it was in your packet a couple of months ago and we sanctioned them and that's how it was found out. Their advanced EMTs were doing extra things. And then when they would go to an adjoining county, they'd be like, well, I can do it over here. And they're like, how? And that's how it was eventually discovered.
Measure of condition.
I'm of the personal opinion that I would like our advanced EMTs that have this skill set to ease the burden on emergency departments, transferring patients who that provider feels it needs to be on a monitor, and there's a shortage of appropriate staff to perform.
So we want to go down that route. The next step would be surveying regarding costs.
And then come up with basically an essential full fiscal analysis.
And of the existing advanced EMTs and whether they also take that up.
Is there any way to include the need within that survey?
I think one of the things that, well, except from the providers, probably would be the only way there that we can think of. Unless there's anybody else has an idea. I think what we would look at is to see, first off, would the institutions be willing to do it? Which most training institutions probably would, once we develop what it is and they know what that is. The individuals with the cost of time to upgrade to that level, and then the providers with the cost, and do they want to go, the route of that level? And implementing the protocols and so forth, which they probably would. But we wanted to make sure that it was solid with just the one level and not just a cardiac monitor and transport.
And motion, that should be done.
I move that the Indiana EMS Education Oversight Committee pursue surveys as to training institution provider from the advanced EMT level buy-in, as well as physician advanced practice provider surveys to determine need.
Second. Any further discussion? Okay, please call them.
Lee Turbin,
Aye.
Darren Hoggett,
Aye.
Dr. Clooney, Patrick Hutchison,
Aye.
Matt Shady,
Nay.
Terry Harder,
Aye.
John Zartman,
Nay.
Dr. Brown,
Nay.
Matt McCullough,
No.
Andrew Bowman,
Aye.
Mary Ann Dudley,
Aye.
Dr. Nauset,
Not sure he's still
I
on.
don't think he is, Lori Manley,
Aye.
Dr. Yason.
Aye.
Thank you.
Okay, moving on to the next item of business. Mobile Integrated Health Committee.
Thank you. Mobile Integrated Health Committee met on Friday, December 12th, continuing our work. Kind of the big thing we did then was a connection with FSSA. There was a restructured on adult protective services and they did a great presentation. If you're curious how those function and talk to Emily, she can give you that presentation. But that was kind of exciting to do that. We do have a opening of the commission, your membership selected the designation, and then usually we self-select the members on there. But I wanted to make an announcement that the non-municipal EMS MIHCP program member position is open. And so if people are interested in being on the MIH Advisory Committee, please reach out to Emily and I, and we will take that under advisement. And with that, we have a few programs for consideration approval process.
I have a John moment. Is it the big one that moves it forward? Okay. Okay, so we do have a couple of programs to go over today. Just quickly, application process is the same. So if you have any questions about that or have any, concerns, please contact me. Application requirements also remain the same. We still need to know all of that information prior to, putting your application up for review on the committee and in front of the commission. So our new applications for review today are Harrison County Hospital EMS. We have Lynx EMS, Madison Township Fire Department, and Manchester Township Volunteer Fire Department, or Fire and Rescue. The dots are indicative of where they're at. So our first one for review is going to be Harrison County Hospital EMS. They're located in District 9, covering primarily Harrison County. Their initiatives are hospital dismissal, diabetic counseling, decreased utilization of EMS, and elderly management programs. Their goals for their program are to work in partnership with their local health departments to address KPIs that were initially set by that Health First Indiana funding source. They also would like to do a reduction in 911 calls for lift assist by increasing awareness and mitigating those risks, as well as evaluation of those factors associated with the falls. Their providers are going to be required to do, to be current Indiana EMS providers with certifications, as well as a current AHA, BLS certification, or ACLS, PAL certification for those providers. They would also like to add a hazmat awareness and operations certification. You do have to have a current driver's license. And complete the NAEMT Community Paramedicine Education course. Did we have anybody with Harrison County Hospital that wanted to say anything? Okay. Any questions regarding that application? Okay, well, I will move forward. So this one, the map is going to be a little shocking, but I'll explain it. So they are primarily based, Lynx EMS is primarily based out of Marion County, but all of those little dots are where they have stations as well. So those would be represented in areas. So that's why I have all of them listed. So primarily located in District 5, but also are spread out between Districts 8 and 9 with those counties. Instead of listing them, you guys can just take a gander over there. Their initiatives are hospital dismissal, decreased utilization of EMS, substance abuse mitigation, and mental illness mitigation. So their broad goals are to focus primarily on the high utilizers of the 911 system and to decrease those recurring patient transports to improve patient health outcomes ultimately. Their providers are required to be in good standing with company education standards, but there is no educational or certification requirements at this time, just because they are still in the process of building that program. Any questions for Lynx? Okay, so I will move forward. Next, we have Madison Township Fire Department. They are located in District 5, covering Morgan County. Their initiatives are listed there. So hospital dismissal, post-response follow-up, diabetic and diabetic counseling, chronic disease management, decreased utilization of the EMS. They're also wanting to tackle OB and elderly management programs, as well as immunization and outreach and support for those unhoused populations. So their broad goals are to assist their residents with medical care that prevents them from needing extra emergency care. Their providers will use a tool for patients and residents. They want to improve their quality of life, quality of medical care and improve that patient education of their overall health. They want to limit the needs of extra emergency attention moving forward. Their outcomes will ultimately result in healthier patients, limited 911 calls, and more patient education for their specific needs. Right now, providers involved in their program will attend the community paramedicine and MIH certification course. Did we have anybody with Madison Township Fire that wanted to say anything else? Or anybody online? Okay. Hearing none, I will go forward. So our last application is for Manchester Township Volunteer Fire and Rescue. This is located in District 9, which is one of our very rural areas in Dearborn County. So their initiatives are kind of broad as well because they are in a very rural area. So hospital dismissal, post-response follow-up, diabetic counseling, chronic disease management, the decreased utilization of EMS, their substance and mental illness mitigation, OB and newborn management, the elderly management, and immunizations and vaccination initiatives. So their broad goals for their program, they are still in the building phases as well. They're really just wanting to improve the overall health and wellness of the community because it is such a rural community. They're kind of those first people to the scene. Their providers will be required to be in good standing with the state with education department standards, but no additional education or certifications at this time. Those are the programs I have.
Our committee voted to recommend approval for all four, and we asked the commission to approve all four listed there: Harrison County EMS, Lincoln EMS, Madison Township Fire Department, and Manchester Township Volunteer Fire and Rescue.
I will need to abstain voting on Harrison County EMS. I don't know if that requires two motions. I had forgotten how we did that last.
Your abstention.
You can just abstain from the one department.
Okay.
Move to approve.
Second to approve. Second. Any further discussion?
I have a question. On the Links EMS, is that a private service? So will that conflict with any of the other MIH programs in the counties?
What's it?
Will that conflict with any of the other programs, like within the counties, like, the fire departments?
No, they should be working in conjunction with each other at that point.
A few of the areas are not served by MIH.
Well, I was looking at the surrounding counties of Marion County,
Yeah,
and so I know a lot of those have MIH programs.
yeah, a lot of the ones around that donut are kind of saturated with programs, but they do serve different communities. So some of those smaller programs stay within those areas.
For both Links and Manchester Township, they are both obviously still in the early developmental stage. Do they do additional follow-up prior to implementation?
So I've been in contact with those individuals that are going to be in charge of the program. So they're looking to build out things. So they are in contact with the office very frequently.
And they do request periodic updates to the MIH, so we have to send back with our masters.
With Manchester Township, was there a concern that they had no additional training requirements for the MIH community? Since we have not adopted any requirements, we've left it up to the individual providers, talk with their medical direction and determine what's needed. I think when they first talked and they applied with Emily, they were uncertain, and I think now they're realizing, now they understand what some of the opportunities are, I believe they will have training.
Especially as we look to sustainability and reimbursement, hopefully, obviously there's gonna be some sort of training requirement needed. So now that they're aware of that, we've realized that, eventually if you want to get reimbursement, you're probably gonna have to read some sort of.
The one thing I'll say, on the training requirements, it becomes so dynamic. Some programs start in their niche and remain rather rote in what they do. But like with ours has morphed from ET3 to treat and release to now supporting nurse navigation. So that training has become very dynamic and constant. Bringing back people. Any further discussion? All.
Okay. Lee Turbin,
Aye.
Darren Hoggett,
Aye.
Dr. Clooney,
So I'm staying on Harrison County Hospital EMS and followed by. That's great.
Thank you. Patrick Hutchison,
Aye.
Matt Shady,
Aye.
Gary Harder.
Aye.
John, sorry. Dr. Brown,
Hi.
Matt McCullough,
Aye.
Andrew Bowman,
Aye.
Mary Ann Dudley,
Aye.
Ray Bailey, and Dr. Gable.
Aye.
Motion passes.
Okay, I've asked all the slide here wrong, but I just want to make a point here. Look at that map for a minute. I mean, that's a testament to Mary Kenny, Emily, to the advisory committee, to the commission, we've made humongous progress in what I would consider to be a very short period of time in the age. And the programs in the state are very much varied. And I will tell you, going back 5 years, those that were involved in those discussions were like, we need a singular standard for MIH, we need a singular certification. And a lot of people said then that this is very community specific. It needs a lot of wind and a lot of rain. I think we're finding that out to be true. And it may be a while before we know all of the impacts, but we now have everything from nurse navigation to treatment release programs, to checking up on postpartum women, to administration of drugs to prevent narcotic overdose. And I'm very impressed with what we've accomplished in a short period of time, but that's a lot of kudos to be too specific. So, and the willingness of the providers to step forward into a very gray area with associated costs and who knows where those costs can go.
And the providers are very collaborative with each other, so it's helpful to see the entirety of MIH watch it grow and.
I just give a shout out to Dr. Yazel too. When he travels, he always pushes MIH.
Well, I actually wrote myself a note too. I remember when we first showed that map, a few years ago, I don't think there was maybe one or two south of I-70. So Emily gets out, sits down with them. And now we're very close to statewide coverage to where we can say every user can get MIH services. That's going to be huge as we advocate for programming, funding, initiatives for different things to be able to go and say, hey, MIH can do this because we can do it for everybody. That's going to be a big deal. And I think we're down to 16 counties that don't have coverage. So, sooner we can get those, I think that's just unlock some more, or open some more doors for us too. So.
Moving on to new business.
The main new business, and I don't think it'd be real long, it's more of just a briefing. We knew we'd have a lot of discussion on the education topics, and we did. A rural health transformation program, we wanted to give a quick overview, Dr. Yazel and I did. If you don't recall, I'll get up, stand a little, since we didn't go on. The rural health transformation program, if you didn't follow, was the one where CMS announced 50 billion with a B over 5 years. And so each state was poised over a 5-year period to roughly end up with, about $1 billion. And so the states estimated, and Indiana applied for 200 million is what the application was. Dr. Yazel sat on that committee, so, and they're still reviewing things, so that's why he's not going to give the full briefing. But he represented EMS, and we appreciate that. And honestly, EMS has been engaged in this as the process has developed. As I alluded to, the next slide talks about the fact we did hear back, and what's interesting on this very fast pace. And so we had, Indiana had to apply within a couple of months, and then we heard back. And the way they're operating with it, we sometimes call it a grant. But it really is a funding stream because each year they evaluate your participation. And if you promise to do things you didn't do well, the next year you might go down. If you did very well, you might get more. So for year one, it was announced that we received 207 million, so 7 million more than we anticipated. So they are looking at additional expenditures for different items. But grow is the term that the governor had included in the application. and that's growing rural opportunities for well-being. And that is kind of the 5-year initiative to fund rural programs. There are a variety of priorities. I listed up here the 4 main ones that I saw that intersect with EMS as a whole. And the first one is a medical operations center. The MOP concept we work on at RMOX for regional, but they've kind of gone more of a statewide. Do you want to add anything on that? That's been Dr. Yeasel's.
I think most, I'm certainly open to any questions, but I think a lot of you have heard me talk about it pretty incessantly for a couple of years. But it's moving forward. I think it's going to have a big impact on patient flow for interfacility transfers, eventually destination guidance, access to care. I think another big shot in the arm for mobile integrated health potentially as we move into phase 2 and phase 3 of it. So just a ton of potential there.
I'd be able to grab some advanced EMT data.
The initiative number 3 was growing improved patient outcomes through enhanced interoperability. That is one, and health department's kind of been the lead on that. And they have been working with us, and we've been very engaged in what they're trying to do. And if you have questions, by the way, Dr. Yeasel can answer a little bit from the committee. I, of course, am engaged. Corey has stepped up and I asked him, and he has kind of been a little bit of a point person. So he's first on a lot of this. So if you need to ask him, but IDOH actually reached out to us on the data, and what the goal with interoperability is. They were a little bit surprised to find out that EMS crews cannot access patient records or find out information when they're on runs. And so that's part of what they want to fix. They want our patient care reports in the Indiana's Health Information Exchange, but they also want providers, particularly MIH, but other providers to be able to pull data back so that way we can have better understanding of the full patient background. So that's something that is being worked on. But it also includes an MIH component that is under this initiative that will be implementation of a MIH data platform. Because if you tell me right now, if you ask me, I can tell you how many approved programs there are. But because we don't certify or otherwise, we don't really know how many people are MIH providers. But we also don't know what they're doing. And that sounds horrible to say it that way. We know what they're doing broadly, but is it, for instance, if you have one, some places call it patient, some call it a client or otherwise, if you're reaching out to them and you have a phone call, is that an interaction? Are we going to track interactions? How are we going to track to get data? And we've been struggling with that with the MIH committee. And one of the things we would like to do is offer a data platform that would compile statistics for MIH so that we know what is being done and we can quantify that and hopefully qualify that and show that it is bringing value. And so we are looking at that as potential in there. And as part of that, you will see, and thanks to my team, particularly Corey, on drafting a proposal, and we will be looking to add more MIH staffing to help out there, both with growing programs, but guide the programs, but also particularly on the data aspects to make sure, because we understand these programs are tracking it somewhere, because a lot of them rely on grants. So we know they're tracking, but there's a bunch of data platforms, and we're going to need to integrate them into our one system. And so we are going to have MIH staff to do that. Anything you want to add on that, Corey? Okay. So we are working on those, and thank you for the hard work, Corey and staff on that. Initiative number 4 is pediatric and OB readiness in rural emergency departments. So as emergency departments, but EMS has been very involved. Dr. Yeasel and I are both involved in that group. And we basically, what they want of us is to conduct a needs assessment of our EMS providers to look at emergency services for children as guidelines. And we're going to look at their guidelines
and see, do we carry the capabilities and the equipment that they recommend? If we do not, then the second part of that would be funding set aside to fund so that that way we can help organizations get the equipment or training or services they need to meet the emergency services for children recommendations. So that's very exciting from that part. And so we will be looking at both, where we stand in terms of the emergency services for children, pre-hospital pediatric readiness. But we'll also then be doing a needs assessment of what equipment and what needs there are for OB. And I think the part of this too, where they tackle is, and you've heard Dr. Yezel and I talk about, and him more so, but maternity deserts and the fact they're out there. And this initiative understands that and says, if the hospital out there and the closest one is not capable of OB care, then who is going to be picking up that I say slack, that sounds judgmental. But there's an opening and a lack of preventative care sometimes. So we need our providers to understand the issues associated with that maternity, and therefore that is what they are trying to fix with education and other offerings there. Initiative number 12 is make rural Indiana healthy again, regional grants, and there are 8 regions that people are paying attention to the grow concept. There is kind of the map that is out there for the region we have identified as qualifying because of being rural in nature. But that I will pause and see if Dr. Yezel
Very, very quickly. In addition to that, our website is up and running now for this GROW program. So there's a lot of information I encourage you all to go look at. That's www.in.gov/grow-roll-health. So please, if you're interested in any of this funding or how this is going to work, I encourage you to go to the.
Mr. Chairman, I'm open to questions or comments.
Had to switch to my.
In that meeting yesterday, there was a quick speak.
So I'm using my former.
It said no government agency available for the funding.
Correct.
Excluded the local health department.
Local health departments will not be able to specifically apply for that, but what they're doing is Craig discussed, it'll be a refill grant application. And then from that point, the money is distributed.
To government agencies, all that. So the government agency would be the influence, they can't be the awardee.
Government agencies will not get. Is what the last thing.
So like the government, as far as EMS, it's municipals would be.
I will take that back and ask.
That's what I'm sure.
I'll ask.
We'll move on to old business or some business now. There's going to be a lot of stuff in the education opinion. So, administrative proceedings.
Okay, on the administrative proceedings, the main update there I have is, you have in your packet, the main one that I have, we have one new appeal, and that was in your packet as a sanction as well. And that was, as a follow-up on Troy Delaney. We did issue administrative action for violating probation terms. And there is an appeal pending on that. So that will be an additional.
So, nothing else entirely should have this. So.
No action items.
Nothing with administrative rulemaking.
We're still reviewing the draft rules compared to trying to consolidate and de-escalate them. So the goal is trying to get that to you by May.
On the staff report, state registry.
All right, fire data. As everybody probably knows, NERIS is in place as of January 1. That's pretty much what I'm doing right now is NERIS. And if you thought working and talking to EMS people were hard, talking to fire chiefs that realize that they need to do something once a year is even harder. So we're getting that done though. We're getting it in there. We just did another image trend update 2 days ago as well. So it's coming along. I will say there are questions right now that I cannot answer. I'm getting a lot of questions from fire departments asking different questions. I am not knowledgeable enough on it to know it. As you know, we don't have a data manager right now. So I'm trying to get those answers and get that back out to the fire departments as it comes in. But they should be doing their nearest and not NIFRS report as of January 1. Also working on annual report numbers. I've got Monica working on annual report numbers. And so we just ran for fire incidents for the state of Indiana. It was over 750,000 runs for fire. We're also, I've got applications for the data manager. I have not set up interviews yet, but gone through those resumes and whatnot, and we'll be setting up interviews. For EMS, we're still working on the 3.5.1 when that's ready to go. It's not ready yet. Again, working on annual report for 2025, over 1.3 million runs. That was up over 20,000 runs from last year. I think part of that is also with field staff working to make sure that everybody is reporting. Every once in a while, we still dip down to that 92, 93%. So providers change software companies, and that if it doesn't get turned over with us on who it is with the integration account and whatnot, they dip, but we get them back up. So I think part of that is getting them back on track. Any questions on data collection? Okay. For operations, just want to remind everybody, if anything changed January 1, with elections, whatnot it is, please make sure that you're notifying your district manager, make sure that you're updating your ACADIS portal for the organization. Again, if you don't have permissions for your organization, there's the agency roster request that you can get in and fill that out. That will ping me to send you a permissions form. And then also make sure you're checking your expiration date. We still have January 1, 2026 expiration providers that have not submitted a renewal app yet. So we need to get those done. Any questions for operations? And I will just end with, although I am a Purdue family, go Hoosiers.
And repercussions will be followed.
So it should have been expired December 31st, not but we're down EMRs from third quarter of 25, also EMTs, advanced EMTs, down paramedics and primary instructors. 31% of the EMRs for last quarter of 25 decided to not renew or expire. 42% for EMTs that did not renew, 21% of advanced EMTs, 10% of paramedics, 13% of instructors. So we are down 503 providers certified from third quarter of 25, fourth quarter, but we're still over 25,000 providers. We did 171 audits. 13 of those were not completed or there's no response, so about 8%. Did have 5 sanctions due to dishonesty. Renewal. Criminal convictions, criminal charges, 58 individuals indicated to us they had a criminal record. 7 notified us that they were arrested in the fourth quarter of 25. 36 of those were resolved. 13 were waiting for more information. 8 are in court, and we have 1 for a team review. PSID applications, please remember they are normally returned within 24 to 48 hours, depending on the weekend or holiday. Remember to only apply 1 time. We do get it the first time and the second and third, but just do it once. Check spam folders. Sometimes the emails will go there. And reciprocity applications for licensure and certification, still 24 hours turnaround time. If for some reason you're not seeing that, please let us know. Might be something missing somewhere. Insurance.
On the slides I have here. All right, so we did, as you remember, we did have, of course, the mandatory primary instructor update that we did many in-person ones, and then we did require the instructors that did not attend one of those to complete the online version. And we did yesterday run some reports to see how many we had, how many instructors we had left that had not completed that. let's see, and of course, attending one of the forums or online did count towards your adult education techniques. So had to attend at least one of those in person. And so if a instructor had not completed that before the end of the year, then what we were talking about is they were going to have to complete that online process. Otherwise, we were going to then make their PI cert inactive. They weren't basically going to be able to teach any classes until they completed that update. We already talked about that. So I did do a graph, and this graph, this is our one from the Live PM forum, the Live PI forum.
Showing how many.
Yeah, do we have the one? That's the one I was looking for. So this particular graph is showing that we still have about 116 instructors that need to complete the online training and the exam as well. That number has gone down a little bit even after yesterday before I left work. I think we were down to like 114, so they are still working on it. But we had 155 instructors that did the, or 151 instructors that did do the online version. So what we did is we ran Corey, between Zach, Corey, and I, we ran a list to see the people that we had assigned to do that. The ones that had not completed that, we did generate an email, and Corey sent that out to all of those non-compliant primary instructors yesterday, explaining, you know, what their requirement was and that we noticed they hadn't completed that. And that we gave them until January 31st of this month, the end of this month, to be the last day to complete that requirement. So between now and then, they would need to go in there and complete that. And then ACADIS would recognize that they have completed that requirement. So what happens if they don't complete that? So if they don't complete that, what the email outlines is that if you did not complete that by February 1st, we were going to take your primary instructor certification and we were going to move that to show inactive. Once you did complete that, then we would give you that right to be able to instruct again. The other thing that we mentioned in the letter, if I'm not mistaken, Corey, is that if this isn't done by the time that they renew their PI and they're still inactive, they would then lose that certification, correct, Corey? I'm not.
Yeah.
Okay. So we did do that. So between Corey and Zach and I, we will keep an eye on that to make sure that we try to make sure all those people come through. I have had a couple of people reach out, and I had one that had attended, and I remember her being there, but she didn't do the QR code because she was just helping me set up. So I've kept some stragglers like that. But for the most part, I think the mandatory PI forums were very successful. And I know it was a lot of work on all of our parts, but I think it went really well. So we will keep you up to date. Any questions about the mandatory PI forums?
Have you noticed that on 16, have you noticed any training institution or geographic fields that, or maybe somehow miss something?
Exactly. You know what? I don't think that we have looked that deep into it yesterday. We just ran that report, but we could certainly, between the three of us, go back and look to see if there's certain areas or if it's just kind of scattered. That's a really good idea. Exactly. I know there were some up north by me and whatnot, but yeah, that might be interesting to see if we can kind of narrow that down. The other thing I wanted to bring up is that we still are working on this. It's been an extremely long process for Corey and I, especially Corey, because he's the lead person on the contract with the National Registry between the state of Indiana, the Fiscal Department, and National Registry. I know we started talking about this early on in the PI forums, but we still are at the mercy of our state to go through the fiscal process. It's my understanding, Corey, correct me if I'm wrong, that the contract has been signed by National Registry. It has been sent back to our fiscal department. And we were on a meeting between the two parties this week. And basically, it's going to take probably another month because what Corey and I, this has been such a learning curve for us. What now has to happen is that document, that contract has to go all the way back through the approval process up through the Attorney General. Once that's done, then we can implement it and give out information as far as when we're gonna start this, who's gonna be eligible. But fiscal said it takes about a month. So this is a process that we have been banging our heads against. It's been a learning curve. And basically, whenever we look at doing a contract like this, Corey, I think you'd agree, we're looking at a good 9 months, if not a year. So, you know, we feel bad because we put this out here. We're saying it's coming, but we're kind of at the mercy of that whole project. So it is still in the works. So stay tuned. Lastly, the pass rates. I wanted to give you guys some pass rates from National Registry for 2025. However, their website is still having issues. They currently still have their portion of their website. I can't pull stats right now because they are still trying to figure out why it's inflating everybody's stats. So if I were before, when I ran stats, it showed like we were at a 90% pass rate for EMTs. And so they are still working through that. I probably will have to contact them because I'll need to pull stats for the annual report. So hopefully they can get that fixed. And they realize a lot of states depend upon that information. So I will get that to you as soon as I can. Any other questions, comments? That's it for me.
Not a lot today, to keep it brief. We are continuing to implement National Registry as an example, our fiscal year 26 initiatives, the 4.1 million. We did do the IDHS AD grant for BLS non-transport organization and are still accepting applications on that. So that's an opportunity. From the EMS Compact, there we are the one positive I had hoped to be able to announce. We are this close to having our data into NIPSCID, the national database. And that should be done by the end of this month. So next meeting, I hope to announce that we'll hopefully have successful. We've been doing test data and everything is on track for us to be integrated. Finally, we have 9 states that have actively developed legislation and are working on legislation, I should say. 3 that have pending. The none pending are right next to us. However, the surrounding states, the state of Ohio, the governor has indicated as part of their rural health program that if they got money, they would join the compact because you got extra points on the application if you were a member. And so presumably if he keeps his word, then they will look at joining. Kentucky is also seriously considering, has a copy of the legislation and maybe someone to join in the future. NSIMSO, we had our annual board retreat looking at some interesting prospects. We are under evaluation right now due National EMS Investigator Training Program, National EMS Informatics Administrator Program, framework for BLS training institution standards to live up to, and then a NSIMSO recognition for BLS training programs. It'll mirror a little bit accreditation, but those will be voluntary programs, but ways for states and training institutions to kind of up their game and also get recognition. So okay, as those potentially advance, I'll keep everyone updated on that. There is a new guidance document, NSIMSO release, that you might want to look at. It targets the state officials, but it's a good one for anyone, and that's available on the NSIMSO website, or I can get it to you. Pre-hospital transfusion of whole blood and blood products considerations. They did the medical directors and a few other councils did an excellent job compiling that, and it's a nice resource. There are meeting dates if you missed them and people want them, then those are the meeting dates for the rest of the year. Other than that, I am open to any questions.
Any questions for Dr. Kidd? Hearing none, let's move on to statement report. Dr. Gates.
Just a few things in addition. One thing forgot to mention, we were just talking about, there was the state webinar on the Rural Health Transformation Act, but there also are individual webinars for each region. So again, I highly recommend if you're interested in getting on your regions once you know more specific information, those are coming up. We'll get those out to them. I don't have them available for me right now, but they are out there. And also, and I mention it every time, stay involved with our tracks, North, Central, and South. They're meeting the next 3 Wednesdays at 10 a.m. That's another good way to get trauma information, get your seat at the table. There's funding opportunities, especially for those of you who are looking for, to start blood programs or other things like that. So really recommend everybody get out to those. Along those same lines, the Blood Coalition for Indiana's meeting the 21st at 10, correct?
Yeah.
At Vernon Township Fire with blood drive afterwards as well?
Yes, correct. I believe that the blood drive starts 1 Nation at 10 and then blood drive is 1. There's a virtual option also.
Awesome. It's just a great time to trade, share ideas. Usually one of our programs kind of gives an oversight of what they're doing. Just a great opportunity again to not reinvent the wheel over and over again as we continue to build our capacity there. For any of these ideas, especially for the Rural Health Transformation Act side of things, start thinking of your ideas of your area. I think this is a great opportunity. It's kind of the perfect match. The state's saying, hey, these are the things that are important to us at the state level, but we don't want to dictate to you what you need at your regional level as well. So there's opportunities for both. So start thinking about some things that would be important and impactful in your region, run them by us. There is a point here very soon that a lot of us will kind of have to go dark because a lot of us, I think, are evaluators or other things like that, to where from an ethics side of things, we'll have to go hands off. So these things are all moving really fast. I would love to give you a year forewarning to start putting these things together, but that's just not realistic on how this information's come out. So it's going to move fast. So, but again, I just think it's a huge opportunity for us. The other thing I noticed is when Corey was talking about, we did 171 audits and there were 5 dishonesty things. My whole goal educationally has always been to have so many good education opportunities that when it's time to re-up that, everybody's like, oh, well, I'm good, instead of these. I don't know what we usually run, but I thought that was a pretty good number that shows that, a lot of us are doing it the right way. I just thought I think it's a good testament to your guys working your oversight and a lot of our educators out there to put, good quality offerings that are available to all of us who are spread thin and busy. So just like to keep building that. And then the last thing I just want to say, I just want to commend the meaningful discussion that we had here. I know a lot of times this meeting is just like a big, long report out. But I think, we're all on here because a lot of us have different expertise in different areas. And that's what people need to hear and see and understand different viewpoints. So, we shouldn't always have unanimous votes if we're tackling tough issues, right? And so I think it was just good to hear different opinions and things like that. And really like to see that continue too. So I thought that was great. Last but not least, I'll try not to burn my couch either in celebration or sorrow when my Hoosiers play tonight. So they'll bring it home. So we'll see.
It's your slide.
There you go. Yeah.
So I knew it was coming.
So thank you.
Any questions for Dr. Gates? Chairman's report and direction, I do not have a lot, and I would call attention to the fact that I believe NAMSD is less than 2 weeks coming up, so there should be some EBM or potentially position papers coming out of that. I know there's a really, really big push right now back on not only the long spine board issue, but on the elimination of C collars as well. And so I really fully expect there to be something come out of that. So.
And just to add to that, I co-authored a report that's being presented as a addition to NASP on advanced practice providers in EMS. So there'll be a session for that I helped create. Unfortunately, won't be there to participate.
You just can't seem to make it to that one, can you?
January sucks for my group to get away.
Yeah, it's a good first time in a long time I'm here. But we expect to see some good things come out of that. Like I've said before, typically we'll see some preliminary numbers come out during the Eagles meeting in June, and then generally you see it full-fledged studies by January. So there should be a lot of good things coming out on cardiac arrest and trauma both this year. So I'm kind of waiting anticipation of those. Just to reiterate again, I think someone said it earlier about checking expiration dates. there's been a preponderance of people, myself even included, that have looked at the numerous certifications and provider certifications being managed and go, oh, that one's coming up here very shortly. So I'm now marking it to look at things on a monthly basis so I can check expiration dates, because we all know that none of them tend to land at the same time. So just always be cognizant of that so you don't get caught in the lurch.
Also, sir, at the Trauma Commission meeting in February, I sent forth some information to Dr. Weaver, where I'm hoping they will also discuss at our state trauma level the spinal mobilization issue. And brought it to their attention, so if we can get some input. Because one of my medical directors for EMS in my group wants to move that direction, but there's pushback from trauma centers. So we're hoping to bring it to their attention.
Well, that's one of the things I find interesting about that entire discussion, if you take a segue here for a moment, is when you look at those position papers that are out there, most of them are co-authored by ACSCOT, and then we get to the trauma centers, and the trauma centers tend to be the ones that are saying, no, let's keep doing that. And it's like the front end gets it, the back end gets it, the middle doesn't. So I don't know how to bridge that gap, but I think what it comes down to, we knew for years along spine boards, you need 1,100 patients to have one good outcome. You need 7 patients to have a bad outcome with a long spine board. That's a pretty staggering number, yet we continue to keep moving. C-collars are probably going to end up being worse NNT than those are. At some point, we need to have standardized group of people standing up saying it's time to end the insanity, and I think we're getting close on that one. So, and that will affect training and everything else, obviously. So we've trained for years to go down that. But glad to see a refreshing renewed look at that. And in 2013, I was present at NAMSP when the National Neurological Surgeons Association came forward and begged EMS to stop using C-collars because of the subluxations that we were causing with that and various issues. So I think it's high time to move that direction. But that being said, next meeting is Friday, March 13th here at Made, and I will take a motion to adjourn.
So moved.